I have the pleasure of introducing our plenary speaker, Clem Bezold. And Clem is a futurist. He's the chair of the Institute for Alternative Futures, and he's been involved with the future visioning for a long time. He started in the 70s, actually, and originally did work with Alvin Toffler. You remember him from Future Shock. And Clem's first book was actually a spin-off from the last chapter of that book, and his first book was called Anticipatory Democracy. That's a great title. Clem works with both the private sector and the public sector. He works both in this country and internationally. He works with the Fortune 500 firms. He works with the Cancer Society. He works across the board. Now, as a full disclosure, Clem and I were actually classmates in our undergraduate work. And so it is so fun to see our paths cross again after so long, and it has been a while. In thinking about how, who would have known when we were graduating with an international affairs degree and an international economics degree, we'd end up as futurists and public health people. You just never know where you're going to turn out. So it's great to see our paths cross again, and Clem's done a lot of work, a surprising amount of work, in the areas of health and public health. And his visioning has been linked to public health issues around the world. He has done work with the World Health Organization, NIH, and of course RWJ and Kresge Foundation. One of his books is actually titled The Future of Work and Health, and that book was dubbed the Book of the Year by the American Magazine. He does and has done much work on the Hill, doing visioning related to health and innovations on Capitol Hill. And one of his more recent works is Primary Care 2025, which includes looking at the leveraging of social determinants with community health clinics, work that was long overdue. He's done work with the military, and particularly really visionary work on military health, of all things. So he's worked with DOD and, of course, DHHS. But enough said about that. We are going to have a deep dive this afternoon at 1 o'clock. So as you come up with questions during his talk or things that you'd just like to know more about, there are little sticky notes on every table. Just make your note and bring it with you to the deep dive at 1 o'clock. And so enough said. Clem's going to be talking to us particularly about Public Health 2030, which is a study of scenarios about the future of public health. And with that, I turn over to Dr. Bezold.
Great, thanks, Lee. It's a pleasure to be here, both because you're in public health and because you're thinking about quality. Two subjects near and dear to my heart, and I will say some things about that before I get into the scenarios. But essentially, we've created this tool of scenarios for Public Health 2030, funded by the Robert Wood Johnson Foundation and the Kresge Foundation, and it's a critical piece of learning for you folks. And I'll walk you through those, and in the process, let you know that each of you is a futurist, and that you'll be exercising your futurist capacity in the course of the conversation. And so one of the things that Lee has raised with me is to say, define a futurist for us, and in particular talk about looking at trends and how that plays into what we're looking at. And so basically a futurist is a person who helps organizations and communities think about the future, what might be, and we argue this is really important, what might be and what you want to be. Plausible future and the preferred future. And that involves a number of activities: environmental scanning, identifying risks and opportunities, using scenarios, looking actually at forecasts and putting those together into big pictures or stories about what's going to happen. And that's the core of what I'll walk you through today, is the Public Health 2030 scenarios. But visions as well and preferred futures are part of what's really important. And it's a critical question for all of your organizations in terms of what's the state of your vision, how significant is it for your workers across the department. And we argue that all of those are a piece of using and doing futures. And so, and each of you is a futurist. All of us are in our day-to-day work. You do environmental scanning. You look at trends affecting your program, your department, the state, your community. And you do that in a variety of different ways. And futurists just have a number of frameworks for doing that. But one of the questions that Lee raised was, so what are the big trends when you look out? And so I've got a couple of lists here just to illustrate when groups look at what are, go beyond the United States and just say overall, sort of what are the kinds of risks that we're facing. And so extreme climate change heads this list from the World Economic Forum and one of the associated groups, but nuclear war, ecological catastrophe, global pandemics, clearly a public health related issue, but global system collapse in a number of systems that could go. The exogenic risks are interesting in that a major asteroid impact, and that could always happen, and increasingly we'll get warning for it, but a supervolcano, and so those of you out west know that, Old Faithful sits above one of the biggest potential eruptions, and some people think that it may have led to the extinctions of animals before. So we've got some risks out there. And any folks from Missouri here? Okay, so you undoubtedly know about the New Madrid. And the New Madrid could happen in a way. The biggest recorded earthquake in the United States was in 1812 around New Madrid, Missouri. It was so large it created a lake and made the Mississippi River flow backwards. It was felt in New York and in Chicago. When the New Madrid occurs, the buildings in Chicago, the skyscrapers, will slap together. Bowling Green, Kentucky, on the river, will largely, the river cities near New Madrid are likely to suffer extreme damage. And that's coming, and it happens every 200 years. 1812 is when it happened before. That's coming. So if it's not on if you're in that region and it's not on your sort of public health threat list, that's among them. So those are the kinds of things that environmental scanning looks at. But I also wanted to bring another group of another list from, this is the UN, the Millennium Project, a project that I think particularly well of. But it also points out that when you look at these risks, it's both risks and opportunities. And so sustainable development, climate change at the top, clean water, population resources, democratization, global foresight and decision-making is actually a significant opportunity for steering into these futures. The rich-poor gap they identify, and on the left side, a variety of issues, including transnational organized crime. And this group has pointed, I've learned a lot from them, but the point is when you do environmental scanning and you say sort of what do we have to worry about and what are our opportunities, you come up with a variety of lists. Climate change headed the list for both these groups. And I'll say in a minute how, as we did the Public Health 2030 scenarios, how that played in, because it's clearly a significant factor in all of your areas, but what surprised me was the range of variation of extreme weather threats that will accompany climate change that we built into the scenarios. So that's thinking about doing an environmental scanning. But what I also want to talk about is quality. And that we've had, as futurists, the opportunity to look at a number of futures: environment, education, jobs, resources, business itself, and quality. And the American Society for Quality actually changed its name from the American Society for Quality Control to the American Society for Quality. It's the largest quality organization in the world. And we had the pleasure of taking them through 3 rounds of futuring, got them to the point where they do it every 3 years on their own. And they're doing great futures if you look at ASQ's futures reports. But what's relevant for this group and why I appreciate speaking to you as quality folks in public health is the importance and significance of quality. That, and we've been looking at this for 20 years, sort of what's the future of quality? And it led me to understand that essentially quality is goodness. Quality is goodness applied and measured. And that means it's actually a moving target. That quality is goodness. And so we did this activity for the American Society for Quality in the mid-90s, and all of these are available on their website, including the most recent ones. But the forecast that we did is relevant for this conversation, because when we looked at where quality was going, it was in connection with trends in other sectors. And that in the 1990s, another public health group had me come give a speech on the future of quality. And that led to a conclusion which is relevant for this. And I'd argue that the scenarios I'm about to show you, the Public Health 2030 scenarios, in effect filled in that forecast in a way that was consistent with the forecast that we had from the 1990s. So these are the slides. One thing clear is the quality of our slides has improved. So that's a big deal. But along the way, I also want to say, and those of you, we've had the honor to work with a lot of groups over the years, and my colleagues, Jonathan Peck and Roger Fritz, in particular, work with the Southern Public Health Leadership Institute over the years, and I was talking with some of the folks here from that group. And for us, we remember fondly sort of major events. My work with New Mexico last month was significant. The work with military medicine was truly significant. And my colleagues' work with the Southern Public Health Leadership Institutes for a number of years was important. What I'm about to show you is a piece of that, and it's the aspirations model. It's shaped how we do futures, but it's about how we are and how we live and who we are. And that is that if you look on the left, ideally, our aspirations will shape our behaviors. We determine what we want. That also defines who we are, and that shapes our behavior. We go out and we shape the world. And we accomplish, we change the world, we make things happen as we want. And that's, us being who we are, creating what we want, and focusing on that. But in many cases, we're in a situation where circumstances change. The budget is cut, and listening to Emily, wow, you think it's bad? Wait till watch the scenarios in a minute about that. But so the point is that in many cases, our environments change, and we feel hurt, loss, deprivation, and in effect, our behavior is responsive, reactive. We basically try to cope with that situation, and instead of having aspirations, we have explanations, rationalizations, justifications, where people are stuck. And now, if you think of the last few years in yourself and in your department, sort of, where are you on one side of this or the other? And we often move back and forth. But many organizations end up being disempowered because, they just essentially forget that, that they've got aspirations, or they don't revisit the aspirations as their circumstances are changing. And this is, in some respects, it's a decision about how we are and how we, how is it to be human. And it's not a simple conversation, or it's profound in many ways, in that Sigmund Freud said to be human is to be here. To be human is to put up with the shit that comes with life. That's what it is to be human. Carl Jung said, no, to be human is to have aspirations, to find those, pursue those. And Freud kicked Jung out of his camp over this argument. So it's a big, it's a big piece. But the point is that we create, and what Jung said is we as humans, we are creators. We create, and part of what we do here is define our aspirations and how we create. And so as we move through both the futures, and I talk about the future of quality, keep that in mind, that there's a definition of what we're after. So that then applies to this observation we made in the mid-1990s. Across many sectors, there were movements up a hierarchy of value. And essentially, it shows most clearly in quality, from operations, strategies, and vision. And remember that quality from Deming in the beginning was about operations. It was about how you did things and how you did things right. And, but on the other hand, the question is, increasingly, are you doing the right things? What is quality applied to the right things? And that classically is a move up towards vision. So it's quality about doing the right things, and vision is the tool or sector that defines that. So quality is making this movement. But what we also looked at was, if you took healthcare, you could clearly see 20 years ago that disease treatment, disease prevention, community health, and then syndrome prevention, design, and equity is increasingly part of what health care is focused on. And so if you think about the triple aim sort of, in large part, fulfills that forecast. It's not there yet, it's not done, it's a long way till doing it. We're still fighting about what population health is, and as Emily says, you have to watch when you use that word, that phrase population health. But the point is that we are seeing this. And literally the triple aim is a recognition on healthcare providers about moving up, and population health will ultimately recognize this. And there's a huge issue, and you'll see in the scenarios, about how that plays out with public health, because that's what public health does too. But even in military medicine, as we said, in the mid-1990s, military medicine had a major futures project that we facilitated. And they did scenarios, they established vision and goals. And and Emily encouraged us to tell stories. One of the stories about that was that there was a colonel in the mid-90s who came to that. His boss said, you got to go. And the colonel had been in the Army long enough that he could have retired, and he was trying to think what he might do. He went to that meeting. He was so inspired by the vision and the audacious goals of military medicine that he stayed in. He retired 3 summers ago as the Surgeon General of the Army. And he described that as one of the 3 most important professional development experiences of his career. And the point being, developing powerful visions, and audacious goals, or BHAGs, if you know that literature, is a tool related to those, is an ennobling activity. It is moving up that hierarchy with significance, but it connects. And so that particular, and the audacious goals, one of them that was created in the mid-90s was to take the golden hour and extend it to 6 hours. Take the hour in which, if you are wounded and you do not get care, you die, to 6 hours. And they did that. And some of the people involved in doing that can trace back to that event of establishing the goal for their motivation and moving things through. And so that was significant. But across other industries that we were working with, there was this similar kind of movement up towards a greater kind of vision, a less operational, more significant look at what quality is. And so in the mid-90s, I had this public health presentation in Minnesota, and I said, well, what would be the future of public health in this context? And that's essentially public health moving up this value-added ladder, moving up towards vision, towards contributing to vision, towards contributing at a higher level to prevention and the related kinds of activities. And so this same group, that's the Minnesota Community Health Group, called me back the end of last year to do a presentation again. I thought, I spoke to you a little while ago. It must have been okay, like Emily, they asked me back, even if it was a long time. And so I pulled this out, and I was surprised to see this, and pleasantly surprised that what you're about to hear in terms of the public health 2030 scenarios fits nicely with this forecast for fill in the blank in terms of public health moving up. But the point is about quality in terms of what you do as well is that you are enhancing the real activity, quality, and outcomes of your organization. And that part of what I'm saying is both you will increasingly as organizations move up that ladder. And you should also know that even as you implement quality, the closer those activities are to, the more related they are to the vision of the organization, and the more that vision touches the heart of your folks, the more they know the noble purpose of your activities, the easier it will be both to change and to implement quality programs. That was one of the insights that we've gotten from a number of sectors. But so that's my diversion into the future of quality and the hypothesis about the future of public health that I put on the table a while ago. So on to the scenarios. And these are, the Public Health 2030 scenarios were funded by Robert Wood Johnson and the Kresge Foundation. They, start with the premise, so what's public health? And it's roughly the IOM definition that we used roughly is that what we as a society collectively do to ensure the conditions for people to be healthy. So that's, but as you know, the who, what, and how of public health is evolving, and it's not always in consistent directions. You know, hooray for the 10 essential public health functions definition, for accreditation, for the move towards standard and uniform accounting, you know, but there's still lots of diversity. But the public health scenarios, in effect, then explore the factors shaping public health. What are those? And public health's actions to consider alternative paths into the future. So that's what they do using these. This particular project, its objectives were to explore the key forces shaping public health, to ask what are those, and think about those and forecast those out, to consider the future of public health functions, as well as, in particular, finance and sustainability. And so given Emily's talk, at the federal level, there's really significant challenges in that regard. And you'll see in a moment that we raise parallel questions, but also some positive statements depending on other things. And the question that you all face is, what's the state and local physical picture that we built those into the scenarios? And so we then argue that you should build expectable, challenging, and visionary scenarios, 3 different kinds of future space, expectable, challenging, and visionary, that then use those scenarios to facilitate your preparation, your imagination, and your aspiration, including sort of what's your vision, and how does that relate to it. And so scenarios should do that, should stimulate all of those things. And then our objective was to provide and widely distribute the scenarios as a tool for public health agencies, organizations, and schools. And that's been happening since they were released last summer. The deans of schools of public health have used them. A number of health departments, most recently New Mexico, have used them. And we've created a toolkit on our website to use, essentially, to do the slides that I'm presenting with you. There are also videos to walk people through, and a set of tools for stepping into the scenarios and exploring the implications. And I can talk more about that in the deep dive as well. But that's all on our website. If you Google Public Health 2030, it will take you right to that site and on our website that has those tools. This particular project also grew out of a number funded by Kresge and Robert Wood Johnson, Vulnerability 2030, that looked at the social and economic vulnerability in the U.S. What were the futures for that? And it set us on a track then, and we then did Primary Care 2025, funded by Kresge, that has had wide implications and use in the primary care community. Particularly, we work a lot, we have a major health equity commitment at the Institute, and we work with health centers, and these primary care scenarios have been significant for them as well as other providers. But we also did a report on, as Lee mentioned, community health centers leveraging the social determinants of health. Our health equity project had identified that in U.S. healthcare, the group that most consistently goes, the group of providers that most consistently goes beyond clinical care to do public health work, and all of you correct me if this observation is wrong, but are community health centers. Since their inception in the 60s, Geiger came back with community-oriented primary care, and it's like, oh, you're supposed to go out and deal with it. If there's a nutrition problem in your diagnosis, you should deal with food, right? And so they have been doing this. And so, so I said to them, so where's all that written up? And there was nothing. And so we got funding to create the first database, and that's that report. And if you Google that, it will take you there to show what are the patterns of health centers leading to that. I'll jump forward a bit and say in a minute, the scenarios are going to say that when you get to healthcare, patient-centered medical homes, that concept, which is really significant in adding quality and focus to primary care, will be superseded in the more positive scenarios by the community-centered health homes. Community-centered health homes. And those are providers, in effect, pursuing population health in a more structured and informed way. And this community-centered leveraging social determinants of health shows some of the patterns of what they do given the kinds of analysis that we'll see. But, and again, the triple aim will reinforce that at the ACO level, the hospital level, the larger provider level, of what do you do to create population health. And part of it is really looking at the social determinants and how do they affect your individual patient's health and the community's health. So we started with that. And then the fourth of, that led to Public Health 2030 scenarios was Health and Healthcare 2032. Robert Wood Johnson turned 40 years old in 2012, and they asked us to facilitate a couple parties of their, they had several parties. They were great at partying. And one was a scenario party, and Healthcare 2032 was a set of scenarios, and with a national conference, we walked people through those and explored the opportunities and the challenges that we're facing, health and the communities and funders. Ironically, Robert Wood Johnson is transforming itself to pursue the culture of health. And the culture of health first appeared in their screen as scenario 4 in that last set of scenarios. And so they're saying, we aspire to that, and let's figure out more intently what that means and go and create it. So that's sort of the origins of this. As we develop, so how do you develop scenarios for public health? And one of the questions is you consider what are the key drivers? And that forces you to say, okay, so what is it we're talking about? Is it the 10 essential health functions and the way it's done? Is it organizational structure? And what are the drivers? And if you go to our website, we have forecasts for the drivers that we worked with we developed, and we worked with the Prevention Institute in Oakland to develop these. We developed expectable, challenging, and visionary forecasts. And I'll say, again, more about that in a moment. For the drivers, we interviewed a variety of experts. And then we also went out to 3 local health departments and 1 state and actually developed scenarios focused on their territory and their activities as warm-up to developing these national scenarios, and then did the national scenarios. We had a great advisory committee. You may know many of the folks here on our advisory committee, and they ultimately took part in the national workshop we did using the scenarios. The health departments that we used, Fargo Cass Public Health was our rural case. Boston was our mid-sized jurisdiction, the city of Boston Public Health Commission. And Cuyahoga County was our large jurisdiction, over 750,000 was our measure for that. And then the state of Virginia, we needed a centralized state. Those were our cases. And those scenarios are all up on our website as well. So if your department has demographics or conditions that are closer to any one of those, you have the option of using those if you want to do a scenario exercise for yourself. Change out, okay. He told me not to go into the bathroom and talk with this on.
We got a different one in here. It's cutting out. Ernest, go ahead.
He's going to talk.
Great. Perfect. There you go. Great, thanks.
Great, thank you. Okay, great. Should I start again? Okay, so one of the things I've said is that when you look at forecasts and scenarios, they should consider expectable, challenging, and visionary. So this is space, and for your thinking and as futurists, your work, you want to be able to say what's expectable. And expectable, in a sense, is if given current trends, what's most likely? What's the most likely future that you're going to face? You know, Emily pointed to a variety of what I'd call the expectable future in the presentation before the break. And when you start putting all those things together, you know, sort of what's it look like? And ironically, when she talked about Ryan White, maternal child health and cancer screening, being affected by the increase in people having insurance, that's built into our scenarios. We agreed, you know, that was clearly an expectable driver when you start putting those together. But basically, the expected one is your zone of conventional expectations. If you take your best guess of where we're going, and you know, paradigm changes may or may not be happening, but usually they're not. And that's sort of your zone of conventional expectation. What is it that you want to pursue? What is it you think is going to happen in the environment? We argue that that's scenario 1. It's a difficult scenario to produce, but it's really significant because it's your best guess at what's most likely. The second says what could go wrong, and it's a challenging set of forecasts or scenario. And challenges say what could go wrong, and they're a huge number, and most organizations would rather not think about this. They'd rather not think about this. But it's really important to say, given the challenges we face, if you put a meaningful set of those together, what's that future look like? Where do you head? And I should say in our community, in the futures community here, my mentor, I started the Institute for Alternative Futures with Alvin Toffler, Jim Dater, and myself were the three principals. Jim Dater at the University of Hawaii runs one of the 3 graduate futures programs in the US. He argues that this scenario should be nothing less than collapse, and that every system faces really significant collapse that is likely. And I think he may well be right. We argue that that usually is a little too far because there's sort of your active capacity is not so great. So our challenging scenarios are not collapse. They're short of that. But there's this argument that as you think about and develop the futures and forecasts for your arena, you should be thinking about that. But the third one, and the one where, and this is, if you know anything about scenarios or you've heard about them, what I'm telling you now is a different way of doing scenarios than the most commonly used approach. This is the Institute's aspirational futures approach to doing scenarios. And one of the biggest differences is what I'm about to describe, and that is that you want a visionary or surprisingly successful zone. You want to say, what would that look like? And that's important both for you as your organization or sector or community to define what vision is, what is surprising success. And it usually transcends your organizational success. It's usually what's the success of the thing that you're doing and what's that look like. And then what are the pathways to that? And we argue that you should actually develop 2 of those scenarios and look at varying different images of success and different pathways to those. And so when you develop scenarios, then you want to look at what's most likely. And that's a rich, meaty kind of look at all the factors shaping where you're headed. You want to look at what could go wrong, those challenging forces. And then you want to look at visionary or high aspirational scenarios. So we did all that, we put all that together, and then we came up with our scenarios. And I'm going to walk you through these in more detail, but one step forward, half a step back. And listening to Emily, that may be more than half a step back, if as the likely. But there's significant analysis, things going on in big data and access to and quality of care, yet recurring physical and health challenges for communities and public health agencies. The second, overwhelmed and under resources, climate change. Watch that forecast in this scenario and what it does to your communities. But infectious diseases, likewise. Healthcare reform is halted, public health is constrained. The third scenario, sea change for health equity. It's clear that equity is an underlying aspect of the vision of public health. And the question is, so what's that look like under what conditions? What's it look like to pursue it? And what conditions and pathways take you into that future? And what's it look like? And then the community-driven health and equity, there are, in our themes and scenarios, often scenario 3 tends to be government is doing it right and doing it big. Scenario 4 tends to be a more community self-driven path to vision. And so there the question is, and there are a variety of budgetary and other economic factors that precondition these that I'll go over, but scenario 4 is innovation in communities, alternative economics, and the transformation. In effect, the economy is likely to transform. Our economy, the job structure, will change over the next 20 years in significant ways. And that's envisioned in this scenario, as well as the alternative economics that pursue it, and public health plays a role in that, in terms of that scenario 4. So I'm going to walk you through those in more detail. But I want you to take a look at this page on your table. And this is part of your being futurists. And that is that we're going to do a poll of the likelihood and preferability of the scenarios as we go through this, and we'll collect them at the end, and we'll, over lunch, aggregate them and give the results at the deep dive or wherever else they'll give the results. But in this, we use it in virtually all of our sessions. And part of it is to get you thinking about the likelihood. That's this column. Each of those cells is 0 to 100. They can add up to 400 if you want, or 0 if you want, if you think there's no likelihood at all. But what's the relative likelihood of this? And this is an important exercise for you in terms of saying, well, this is a gestalt, a big set of factors you're putting together. And, when you put all those together, what's the likelihood? But equally important then on is preferability. And that is if you, what do you prefer? What's your preferred future? And, do any of these get to 100% of your preferred future? How much, do you like them? And give those that vote. And so that's an important capacity for you. And we're seldom asked, particularly, we're seldom asked to really do likelihood voting, but you may get that at times. But very seldom asked to do preferability sensing. And so this is a little important piece of this, the exercise, is doing that. And I'll give you a chance as we go through to think about it. But so the first scenario, one step forward, half a step back. And I'll come back to this infogram at the end of the scenario one. Each of the ones will have them. And these slides are all available through the website or the Dropbox or wherever they are. But in scenario one, public health agencies advance capabilities in technology and big data analytics. And that's really important because there will be advances in terms of what public health can do in terms of encouraging population health and pursuing it. And while there is competition for public health in the big data space, public health agencies generally are able to play and contribute in that. Public health, though, is constrained by the high costs of health care, even with successful implementation of ACA. And there are variations in public health agencies' technological capabilities, funding services, and effectiveness. So when we started this, we were told there are 3,000 public health departments, and if you see one, you've seen one. It's not quite that bad, but there's still huge variation in terms of public health agencies. Public health funding varies widely. Federal funding for healthcare programs is reduced as access to care improves. So that the Ryan White, the three that she mentioned, plus some others, are cut back. They're cut back in ways that are sensitive. Emily was saying we have to watch, who's getting cut, because in some cases there may be an assumption that people no longer need it because they have access to care when that's not the case. But in this scenario, those are done. Public health agencies consolidate and share services. Most improve their comparability and show positive return on investment. And so, that's in effect sort of what's your value, what's your worth. That increasingly is shown in scenario one. Big data does emerge, and that's data from electronic health records, from biomonitoring data, from environmental monitoring data, from purchase behavior, and other things. And that's put together, and that there's really significantly improved surveillance and analysis. And that's part of what, in public health, plays a significant role in doing that. Public health agencies provide quality control for the data in many cases, and in some cases work to include nudges in social media so that, in effect, social networking, which continues to grow and occupy more and more space in our lives, moves towards better health. When possible, public health agencies automate inspections, and those occur both for food and for other kinds of inspections, and enhance population health monitoring, and that becomes relevant, and improve emergency preparedness. Those are three sort of major core increases in activity. Some public health agencies are confined to mandated services, and again, it varies state to state. Some are allowed to pursue this prevention activities, whereas others are saying, no, keep it in your mandated services. All public health agencies face the effects of more extreme weather events and vector-borne infections. And so climate change is happening, and we will get more extreme weather as is happening this week and last week. That the impacts of that vary widely. In North Dakota, it was the North Flowing River, and the fact that Fargo is like to be underwater. And that happened in their scenario too, when we worked with them. But Boston, had very different, extreme storms, flooding, sea level rise, and including the fact that some of their public health assets are on Long Island in the Boston Harbor across a bridge that was already condemned, and that, and it's the homeless shelter as well. And so there are a number of extreme weather events that will put at risk a number of activities, and that Lyme disease and dengue fever spread in terms of their availability. We did not look at some inventions. If you may have followed this, the fact that they're using GMO mosquitoes. The Aedes aegypti is a carrier of dengue fever, and they have identified how to make a Aedes aegypti mosquito that doesn't breed as well, and do something to those guys. And they've tried it in different places around the world, but they've started trying it in the Florida Keys, where dengue fever has increased significantly. And so there are these mosquitoes flying around, and they are supposed to reduce the population by about 90%. And so we didn't include that in the scenario. That was since we had it. But the issue in general is that you will see conditions that were either not in your district or very rare becoming more common. But public health agencies also use simulations and gamifications to prepare communities and emergencies, and that we get much better at, in effect, simulations for emergencies. Health reform is largely implemented. In this scenario, we made positive assumptions that ACA gets put in place. The expansion of the accountable care organizations does occur, and that they live up to their the expectations that they actually work to control health, they control costs, they pursue the triple aim. Patient-centered medical homes become the norm, and they, again, live up to their definition of quality for primary care, and that readiness gets added. But in healthcare, we also get significant advances from technology in terms of cognitive computing. So Doc Watson becomes significant for virtually all lines of primary care, specialty care. And Watson was the IBM computer that beat humans in Jeopardy in 2011. In 2012, we had the first application of Watson to oncology, putting in front of clinicians all available knowledge around whatever they were looking at in terms of particular cancer care. And that spread. And as futurists, it's easy to see that cognitive computing capacity will take over functions of judgment and discrimination in terms of diagnosis and prescription, and that will be common, it'll be built into the practice protocols of healthcare providers. But in addition to having that in the practice protocols, it will be common for us personally to have a digital health coach, to have a very powerful agent, and the agent will be of our choosing in terms of what the person or animal looks like, and how they respond to us. And it will also deal with us in terms of our personality, learning style, et cetera. And it will, probably be on our smartphone, although our smartphone may become our earrings or our eyeglasses or be embedded in a whole variety of things. But we will have incredible technologies, and they will be relatively ubiquitous, the technologies in the smartphone. But in parallel with that will be the digital health coach, and that will be significant for virtually all populations. And that the public health agencies continue to focus on prevention, but in this scenario, in pursuing the triple aim, there's a lot of heft supporting public health activities. In this scenario, then, the question is, what's the role of public health agencies? And I noticed that that was one of the conversations yesterday, even here, of public health agencies with healthcare providers. And in this scenario, it varies widely. Just as we found in developing scenarios, there's some places where the health provider said, our public health agency has done a great job of telling us how overworked and understaffed they are, and that we can't ask them to do anything. Whereas in others, they play a role of, this is about guiding what kind of public health activities should be pursued. In some cases, it's hiring public health to deliver some public health, some activities. That's a minority of things, but it does occur in some of them. But there's a wide range of public health agencies' ability to sort of play in the space with the large healthcare providers, who often are seen dominating the public health department in their own communities. And so, but there is a growth towards pursuing public health. So overall, in this scenario, healthcare costs continue to rise as access improves. The social determinants aren't really addressed significantly and consciously. They're not big game changers for public health, and there are continued disparities. In terms of a picture of this, there is extreme weather and climate change and slow economic recovery, but it is slow. We get recessions every 7 years. These are unremarkable recessions in this scenario. but you get a variety of also healthy development in terms of communities, walkable communities, safety. You get, there is lots of big data, and big data supplemented by biomonitoring, personal data, data optimization, analytics. Genomic data is included. Nearly all people have access to great primary care, and that's significant. And that public health agencies gain in health, their gains in health overall, but costs continue to rise. And automation shrinks the public health workforce in terms of many of the functions that you do. And that public health agencies are consolidated and share health promotion and prevention is significant. And there is this explicit reduced funding for maternal child health, HIV, breast cancer, asthma, and immunization. So that's scenario one. So any questions about scenario one? And as you think about that, take your sheet and go ahead and write down, is this 0 or 100 or 50 or 30% likely? And then how much do you like it? And you can come back and change your votes as we do this for each of the 4 scenarios. And, okay, so I'll move to the second scenario. So overwhelmed, under-resourced. Again, what could go wrong for public health? What could affect this? In many things. And one is the recessions in this scenario are more severe. We do get, on average, every 7 years. 2008 was, so big, it went off the charts. Well, those kind of bad news ones come again. Public health funding is reduced and many programs are eliminated. That light at the end of the tunnel, it's been turned off. The public health agencies are blamed in many cases for the lack of preparation and ineffective responses, even though you didn't have the resources or the capacity to improve your response capability. The public distrusts public health agencies generally, the federal government in general, and healthcare is also distrusted. As distrust grows, people refuse to get flu shots in greater and greater numbers. There's a highly virulent flu strain that hits in 2020, and tens of thousands of people died. Those are not related, but they are sort of conflated in the population's mind that you get blamed for people not getting flu shots, and blamed for not distributing whatever vaccine did get available when the nasty one came, and that pandemic does occur in this scenario. In this scenario, in all the scenarios, there's citizen science, basically citizens doing a variety of monitoring and public health analysis. But in this scenario, while that citizen science and the related monitoring technology grows, it serves essentially the affluent communities, and it reinforces disparities, that additional aid to public health analysis. Public health care services are cut, and in this scenario, it's not because everyone's getting access to health care, it's because you just don't have the money, and the federal government no longer can pay for those for Ryan White, maternal child health, et cetera. And on the other hand, in this scenario, if you're affluent, you will get excellent care. There's a cure for Alzheimer's. It's just 60 or more thousand a year. So inequities grow significantly, and innovative private sector approaches in general to health for those who can afford them. In this scenario, climate change runs away. And it runs away, and the one that we have in the scenario is the methane belch, or burp, or some people call it other things. And that is that there's enough methane trapped that is being released now, and methane is about 20 times more potent than carbon as a greenhouse gas. And as we looked around and said, in the span of the scenarios by 2030, what could lead to significant sea level rise? And this was a major candidate we built into the scenarios. Since we released them last year, there's more and more evidence that that is happening. And it's happening not only in the north, where it's cold, but in a variety of the other parts of the ocean where methane has been trapped. In this scenario, you get more extreme weather events, including sea level rise, that affects coastal communities. So you get climate refugees not only from around the world, but from the U.S., in parts of the U.S. And unfortunately, some communities don't deal with them any better than some communities are dealing with immigrants at the moment. In this scenario, health, violence, and discrimination worsen in that context, and public health agencies are overwhelmed and struggle to recover. And again, infectious diseases grow. So public health agencies are understaffed and overwhelmed. Many universities and the jobs in public health are really diminishing. And that so public health, many universities shut down and affect their public health programs because there's sort of not, it's not a viable career track. Private sector innovations ignore disparities and vulnerabilities, whereas they don't ignore them in the other scenarios. And they're worsening disparities in health, quality of healthcare access, effective prevention, and other public health services. So that's scenario 2. Again, in terms of summarizing it, on the left, you know, many people are unable to afford care. So this judgment that the Supreme Court's about to make would easily contribute to that if it's not overturned or overruled. We do get severe recession. We have bad air quality. We get cuts in public health that are significant, even though we have the recurring extreme events and accelerated climate change. We get poverty and distrust, but we also get health regressions. So there are places where you can smoke in 2020, 2025, where you cannot smoke now, and that tobacco use re-increases in this scenario. And the vulnerable populations suffer the most, and there's much more violence in this scenario. Again, though, if you're affluent, life is okay. So that's scenario 2. Again, look at your chart and say, how likely is that, and how preferable is it? And if you don't like it at all, put 0, because if you don't put a number, it messes up our average generation. So that's scenario 2. So scenario 3, sea change for health equity. And again, the question, this is a wind at your back. It assumes that certain things are happening. The demographics is leading to what will be, in effect, more millennial voting in a different voting pattern and more minorities voting in ways that actually change political activity. But in this scenario, there are changes in values and demographics. Funding in this scenario for public health improves. Yeah, that's the good news. In large part because of the slow economic recovery that affects your cities and states and their spending. Public health pursues analytics, gamifications, and multi-sectoral partnerships, and the improvements, in the social determinants of health, which public health works on or supports: housing, economic opportunity, education, and other social determinants. Some disparities persist in this scenario, but in 2030, the vast majority of Americans have attained greater opportunity for good health. So that's significant. And part of it is a support for common sense. People just no longer take the extreme partisan hostility that we've had and seen in the past. There's public support for opportunities, equity, and fairness in policies and economics. The national minimum wage is put into place. We pursue health in all policies, both nationally and at the state level. We would think about that. And there's innovation in the use of both new technologies and outcomes. We just say, if we're going to do it, if we're going to grow the community, if we're going to develop the community, if we're going to apply technologies, how do we do it right in a way that supports health? Public health funding improves as economies gradually grow, and the physical strain on state and local governments in particular is reduced. Public health agencies foster additional resources, though, not only relying on those, but they go to businesses, foundations, and ACOs to enhance their funding. Evaluations show positive return on investment in terms of public health activity, and this is really important for this scenario. It is the ability to show, and you quality folks may well be part of your organization's evaluation units, but what's significant for this scenario is that in an environment where healthcare costs continue to increase, yet public health shows overall long-term cost reduction, that becomes significant. And so in this scenario, what happens is that Congress sees that, and by the early 2020s says, well, one, we'll make sure that the prevention fund is at its original $2 billion level. But even more significant, it's shown that the real investment would be to take IOM's recommendation in 2010, which is to tax healthcare services and use that tax to fund population health, public health activities. Congress says, yes, let's do that. And so they create a tax on public health services and as a 2% tax put into effect in 2022 in this scenario. So in this scenario also, public health agencies become health development agencies. The question is that they operate as chief health strategists. And that's a analytic, strategic, cajoling leadership activity, and that they do that. And in the cases where their mayors want to be the chief leader and the chief health promoter, that's fine. The public health agency figures out how to be right there in the background and make sure that that happens, and that he or she does well doing that, and that happens. And that there's a shift generally away from direct services in this scenario, including the health services that now are available because people have universal access. There are collaborative networks and partnerships that public health agencies particularly focus on. They use simulations, forecasts, and analysis, and in this case, readiness is really looked on as resilience, pre-event resilience, in ways that increase equity in the community. And so that some of the best prevention are making communities more multi-income, making neighborhoods more multi-income, multiracial, and that proves significant over time in making communities more resilient. Public health agencies also know who the most cost-effective providers are, both cost-effective and appropriate, for a variety of services. And for population health and supporting population health, sort of who are they? In some cases, that's the public health agency, but in many cases it's not. But the public health agency knows who those are. Gaming achieves, helps communities increase their awareness and commitment to achieving health. One of them is actually a game called Privileged, developed by a health department. Privileged allows people to play and say, sort of, what role do I have? Where am I in this spectrum of opportunities? And who is not privileged? And how does that relate to what communities do? And that has a significant impact in growing. It's played in many communities in growing support for health equity and for relevant policies. Their new technology developments are made to be affordable and culturally appropriate, and that's significant. Public health plays a role in saying, as all these new widgets and digital health coaches and other things and monitoring come into being, what's the way to make sure that those are usable for particularly underserved populations? And the public health agencies lead coalitions, and they get recognized. Now, most people have no idea what public health does. In this scenario, not only do they lead the coalitions, but they get recognized as chief health strategists. And that's a communication issue, and it's a style of doing things. But healthcare does improve. It's largely capitated and effective with access. The ACOs sort of do their job. Primary care supports community prevention. So, as I mentioned, the community-centered health home replaces the patient-centered medical home as the standard for primary care. And that's the expression on the part of primary care that they need to know the community conditions that are affecting health in the community, and they need to say what's their role in doing things, again, in collaboration, in stimulating coalitions, in working with you guys. But that community-centered health home is significant, and it's pursuing the triple aim of an enhanced experience, increased population health, and lower per capita costs. So that's working. And that primary care does support community prevention, and there are those cuts to the public health programs and screening and treatment that I mentioned in this scenario 3. So by 2030, there's better health and health equity and less demand for health care. There are improved community conditions, especially for low-income communities. And the infographic that looks at this says that there are a bunch of things going on: support for vulnerable populations as values are shifting, emergency preparedness with enhanced resilience, new social contract that's fueled by demographic and attitude changes, and support for fairness and health equity are all social movements that are relevant. Community-centered health home replaces primary care, patient-centered medical home. Personal health data is significant. There's big data, again, in all of these. The public health programs are effective with positive return on investment, and that 2% tax is put in place that significantly increases funds available for prevention and public health. There's a national public health enterprise so that you, as public health, really end up with consistent standard, consistent accounting, accreditation moves you forward in a way that makes your operations, while you're not a unified entity, while you're all your local activities, you function more effectively as a consistent national enterprise. And that you're recognized as the health development agency working as chief health strategist. So that's scenario 3. So again, put down what you think is the likelihood and the preferability. And hopefully there's a difference in preferability between scenario 2 and scenario 3. But go ahead and put your votes on that. And so then moving on to scenario 4, community-driven health and equity. And in this scenario, health improvement initiatives coalesce via technology networks into a broad national public health infrastructure. So that happens in this scenario as well. And the value shift to equity was accelerated in this scenario by another major recession and economic transformation. Job loss in this scenario are significant, particularly in the knowledge sectors. The nation tries to come together also with its racial and socioeconomic histories. In this scenario, you actually get truth and reconciliation commissions in communities looking at what has transpired. And public health sheds many of its current functions and facilitates these movements to improve health. So people spend more and more time in social media, and the group nets are one of those things that they do. And group nets essentially are your own really intense social media. Your best buddies are there together all the time wherever you are. And that what public health does is help enable those to do peer uplifting rather than the reverse. And that is spread and aided by public health. Community activity and organizations are focused on health in this. It's more common that that's the case. And public health agencies lead on information quality and community facilitation. So leading on information quality means that there is increased analysis, citizen science, environmental monitoring by a variety of different groups, inspections of safety, of restaurant and food inspections, and of facilities, and of other environmental threats. And that part of the job of public health agencies is to ensure the quality of those information flows and how they're used, including, and I may be jumping ahead, the information on the safety of your restaurants is fed into Yelp and Urban Spoon, together with their food quality and taste preferences of your neighbors, and that's put together. And part of what you do is just make sure that information systems are working, that's accurate, that it's effective, but that's common. I should do a footnote. A futurist, or William Gibson, the science fiction writer, has a phrase that the future is already here. It's just unequally distributed. So the forecast I just gave you was interesting in that we ruled out, in picking cities to work with, the largest cities. We said, LA, New York are off the screen just because they have a uniqueness because of their size. So I'm doing this session in the LA Health Department, County Health Department, and we get to that, and they say, oh, we see ourselves in a lot of this. And I said, like what? I said, oh, we already share that information with Yelp and Urban Spoon. I said, so who else is doing that? And they say, oh, Seattle and New York. So the future is already here. It's just unequally distributed, that aspect of the future, that sharing that information. So it may be coming to a public health agency near you if you're not doing it yet. And this scenario includes it. So health records in this scenario 4 are integrated with other personal and community data to allow advanced health analysis and monitoring. So we really have a sense of what's going on. Community health learning systems enhance community health role as facilitation health strategists. So in effect, you've heard about the health learning systems. Well, there's community learning systems where we actually get serious about community engagement that becomes more intelligent, and that public health agencies play a lead and facilitative role in many of those. Simulations and games improve community engagement and planning, and this is both the kinds of things like resilience gaming that makes communities better in advance. Environmental health evolves, and so climate change is happening in this scenario, but this is the only scenario where we actually have a national effort to slow carbon of significance, slow greenhouse gases, and that we put in place a number of aspects of a climate control strategy, and that public health agencies work in their communities and with partners to reduce environmental impacts and expand renewable energy. That becomes part of the remit for public health agencies. And that there are those highly effective pre-event resilience games that play out in many of your communities to say what happens. And you're able to look over the threats, and the threats increase, and that by 2030 we will have slowed climate change somewhat because of the success of this, but the extreme events will still be occurring. Governments spend in this scenario smarter because they have less in this scenario. There is this extreme, significant recession that affects that, and that governments spend smarter. But unemployment also accelerates, and the unemployment, if you think about knowledge sectors, particularly education, healthcare, legal services, and any places where you have an agent. All of those will see significant increases in the use of cognitive computing. So the Doc Watson that you saw in healthcare, that will play an effect in terms of employment. And so just as you've seen the number of tax accountants be affected by TurboTax, or the number of travel agents be affected by Expedia and those kind of factors, you'll see the need for employment in many of these sectors affected. And that's going to be really profound in terms of, the good news now is that we're just about at full employment. But as these long-term trends play out, there will be significant job issues. And there'll be new jobs created by those technologies, but they will be smaller in number than the jobs that will be displaced. In this scenario, increasingly individuals, families, and communities turn towards alternative economics, alternative modes of production. They get the stuff they need. And that's both from time banking, the ability to share services, to community gardening, to aeroponics and the ability to grow things at home, to urban agriculture, turning parking lots into solar-powered and recycled water energy modalities. So but that's significant, and that just as some public health agencies are supporting community gardening now, that becomes part of what public health is doing, is supporting the alternative economics and saying, where do you need to worry about health and safety effects? What are the right ways to do it? The economic and social justice movement has progressed in this scenario. And in particular, there are truth and reconciliation processes that go in many communities. There's the equivalent of saying, what is it that we've really done over time to African Americans, to other minorities, to low-income folks in our community? What does that look like? And what do we do about it? New legislation promotes economic fairness. And so here there is the expansion of the earned income tax credit. There are income supports, but those are not significant enough to slow down the move towards alternative economics and home, self, and community production of many things. Public health graduates in this scenario are trained for community engagement and advanced analytics. Those are two of the capacities that are core, whatever their majors are. Public health agencies serve as effective chief health strategists, again, in this scenario. And disparities are reduced. And then in terms of the infographics, there are core issues about self-care, and that how do you do that, both in terms of self-health and other factors, and community care. And both of those are occurring, and public health supports those in a variety of different ways. And that again, and this assumes a value shift is going on, and it's a critical wind-at-your-back assumption. And we come back and talk about that if you'd like. But governors and mayors support health and public health agencies. Many of the mayors want to be leaders in terms of cheerleaders for health. The group nets for well-being and connecting people and community, Truth and Reconciliation Commissions are part of what's going on. Again, data analytics is significant along with urban agriculture and other factors. There's generally the positive public health movements that are both recognized and supported by the public and give more attention to what work that you do. And there's a value shift that recognizes equity. The public is engaged, and that there's social movements for health. And again, part of public health role is to aid with those, because many of the functions that public health is doing are pulled back, particularly those direct services activities. So those are the four scenarios. When we typically do scenarios, we compare a variety of things about them. And if you look at the report, and again, Public Health 2030, it will lead you to the full report, the one that Lee was waving. And in there is a matrix that examines and compares those various factors. Here, is, again, the voting form. So let me ask you to go ahead and make sure that you voted on all four on the likelihood and the preferability. And we'll collect those and summarize those. And let me ask if there are questions.
I just wanted to factor in education. I see a lot about education, and right now there's a big concern, college tuitions rising at an incredible rate, and kind of how education might impact public health.
That's a great question. And part of the thing about dealing with scenarios is they're often big to begin with, and we couldn't deal with, we didn't deal with that explicitly. If I were to say, there's a huge question about, and what was it, Drucker? I just saw a quote that, by 2030, our universities as we know them will be dramatically different. And that is and if you know Clayton Christensen's work on disruptive innovations and applied both education and healthcare, there's huge questions about the economic form that universities will have. That's apart from the fact that the return on investment for students, sort of what is it, especially in sectors that may be challenged. If you looked at law schools, that's one of the first ones that students are pushing back. We didn't factor those things into. We just made the observation in one of the scenarios that public health programs, some shut down because there's not enough student demand because there's not enough flow through into jobs. But it's an important question, but we didn't deal with it in these scenarios. Although actually, you may or may not know that the American Medical, AAMC, American Association of Medical Colleges, has an RFP on the street for a major futures effort for that community. And our institute has bid on it. We don't know if we'll get it, but stay tuned and watch them. And I'm curious about how significant those scenarios were, whether we do them or not. But there will be dramatic education issues going forward. Yes.
How does that affect that? Just your thoughts about that?
And so that's a great question. So the AAMC's workforce forecasts, I encourage all of you to look at them. And that I've been curious, and in our primary care scenario 3 assumes that we're going to have a workforce glut, given these various things. And they model the influence of nurse practitioners and physician assistants, but they don't model Doc Watson and related technologies. And we argue that really needs to be factored in. On the water question, when in fact sort of there is these more extreme weather events, and the U.S. in the scheme of things is actually blessed far more than other places in terms of water. There are a lot of shortage areas, but if you look around the world, the glacial melt will have extreme effects on China and India in terms of the water flowing through those communities. At the same time that they can get their monsoons and their flooding will increase in those kind of cycles. But what you raise, halophytes, are saltwater grown plants. And in getting ready for this, Lee encouraged me to add this climate change thing. I looked at one of my colleagues has this. If anybody's interested, I'll send you his slides. He's a former NASA guy, and he went. It was frightened me. And in my group, I have our energy guy, who's taking a more. He still consciously thinks all the things are happening. We coach GAO in developing geoengineering scenarios. Bob Olson, our retired research director, has his own soft path geoengineering recommendations. And he says it's still all a mess, but it's actually more complex than he had thought. But this former NASA person has set out a lot of nasties, and it just is chilling. And this is before the news in the past 2 weeks about the East and West Antarctic ice sheet adding 10 feet each to the sea level rise. The good news is that's over centuries, but they didn't think that was happening. So that's out there. But coming back to the halophytes, so the question is, can you grow salt-tolerant stuff, either in the water, in salt water, or in deserts. And there's growing technology to do that. And some people think that that will be a major activity. Just, you know, if you're near the ocean, water your plants with salt water. So that's being worked on. And for us as futurists, you know, I'd say stay tuned and watch that, or encourage it. But you know, so public health should be aware that there's a set of opportunities that may emerge, but it's sort of like solar energy or sustainable energy. There are amazing breakthroughs out there that say that we may have virtually no cost energy, but it's been delayed and it hasn't been pursued as much as it should have. I'd also encourage all of you, one of the implications of this in terms of the work is there's a book by Jeremy Rifkin called The Zero Marginal Cost Society. And that is, what I haven't touched on is 3D printing and manufacturing, and combined with the things that I've been describing could lead to a condition where many goods, you just go to your local Kinko's or your apartment building 3D printer or your own, depending on what it is, to print. And for a while I had a standard that 3D printing will be significant when it can print a cell phone. Well, about 2 years ago, I was able to print everything but the chip in the cell phone. And it's getting better, and they've just come out with a new wrinkle on clip, a new way to do 3D printing that is 20 times faster and less imperfections and blah, blah, blah. And so the issue here is that there will be just different ways of being. And it's interesting, I've got kids in their late 20s, and I think, whew, they may have a whole new world by the time they're into their 50s in terms of how we get our food, how we produce our work or our learning, how we support ourselves. So those are out there. But the halophytes are the salt-eating plants, and that's a significant option. Other questions? Okay. Well, if there are no, we're going to do the deep dive. Leave your forms at the table, or you can put them in a pile at the table. Either way, we'll collect them and compile those after the break, and we'll give you the results at the deep dive, or they'll share them. And Lee, since I'm the only thing between this and lunch, do you need to make any comments before we adjourn? Do you need to make any comments before we adjourn? All right, well then, folks, it's been a great pleasure and honor to be with you and present these. Thank you.